So good to see you, man. Such a long
Yeah,
time.
such a long time.
Mediastinum. So, for the sake of localization of the mediastinal abnormality, traditionally the mediastinum was divided into three compartments by Felsen, and we had used this classification for a long time. It divides. It was based on lateral chest radiograph, divides mediastinum into the anterior, middle, and posterior compartments. In anterior compartment is when we draw this imaginary line from the interior wall of the trachea and behind the heart. And then we draw the second line, which is 1 centimeter behind the anterior margin of the vertebral body. So this was middle mediastinum. Anything anterior to the first line was the anterior mediastinum. And behind this blue line was posterior mediastinum. So this was based on lateral chest radiograph. So in 2014, International Thymic Malignancy Interest Group proposed this classification to standardize the this medicinal compartment classification and to localize these medicinal masses. So now this has become the standard of classification. This is used by radiologists, surgical oncologists, medical oncologists, radiation oncologists. So this has become a standard to use this. This classification is based on CT. And in this classification, this is a three compartment classification again. We divide mediastinum into the prevascular, which is anterior mediastinum, visceral compartment, which is middle mediastinum, and paravertebral, which is posterior mediastinum. So this purple is the anterior mediastinum, which is bounded anteriorly by the sternum and posteriorly by the pericardium, interior aspect of the pericardium, as it's wrapping around the heart and the vascular structures. So this is all included in the anterior mediastinum. And for the middle mediastinum or visceral compartment, again, we draw a line, imaginary line, which is posterior to the anterior margin of the vertebral bodies. So the space between the posterior aspect of the anterior compartment and then this imaginary line is the visceral mediastinum. Anything behind this imaginary line is the posterior mediastinum. So this yellow is the posterior mediastinum, this is visceral mediastinum, and this is purple is the anterior or prevascular mediastinum. So one thing important to remember is this classification is based on anatomical landmark. There are no fixed facial planes which is dividing this compartment in like the mediastinum into different compartments. So disease can spread from one compartment to another compartment. It is important to localize where the disease is like a centered or predominantly located. That helps us to generate the meaningful differential diagnosis or narrow down our differential diagnosis. Similarly, like, in terms of superior and inferior extent, like there is no fixed plane which is separating the thoracic inlet or neck from the mediastinum. So disease can spread from the mediastinum to the neck. And similarly, inferiorly, the disease can spread from the mediastinum to the abdominal cavity. So again, this is important. There is no like a fixed facial plane. This is all based on anatomical landmark to help us localize the abnormality and generate meaningful or narrow down our differential diagnosis. So in terms of imaging modalities, chest radiograph is most commonly the initial modality because most of these masses are asymptomatic. Patients may just present without any symptoms. They are identified incidentally. So chest radiograph is good for localization. But when it comes to further characterize these masses, CT is the imaging modality of choice. CT can help us identify calcification within this mass, presence of fat, and most importantly, whether these masses are cystic or solid. We can see the enhancement pattern of these masses, which can help to decide if the mass is hypervascular or not, because there are different differential diagnosis for the hypervascular masses. And it is helpful for the localized staging of these tumors to help know the relationship with the adjacent structures. So MRI is used mostly as a problem-solving tool, specifically in the prevascular and visceral spaces, when it is difficult for us to differentiate between the cystic and solid masses based on CT. If the mass has high attenuation value, then we need to know is it cystic or solid. And for the posterior or paravertebral masses, MRI is the imaging modality of choice because it can give us better delineation of the mass and relationship of the mass with the spinal canal and its structures. PET-CT is not used for the initial diagnosis of these masses. It is used basically to stage the tumor, specifically like lymphoma or some other malignant tumor of the thymus, which can extend beyond the chest. So PET-CT is good to look at the initial staging and to look at the treatment response and follow-up imaging. So now let's proceed to the how to approach these masses. So the first step, as we all know, is the localization. Based on the localization where the mass is located, we can generate a meaningful differential diagnosis. Once we localize the mass, the next step is to identify or characterize these lesions. So again, depends on whether the mass is predominantly cystic or solid. Does it contain any calcification, any fat? Is there any what is the enhancement pattern? Is hypervascular, non-vascular? So those are the features which help us to characterize these masses. And then finally, the patient's demographic, age, and gender are helpful in narrowing down our differential diagnosis. So we will start with the prevascular mediastinum. This is the most important compartment in the mediastinum. Most of the masses, more than about 50% of the masses, occur in the prevascular mediastinum. So we will start with the prevascular mediastinum, as I already discussed with the boundaries of this space. The major contents are thymus, fat, lymph nodes, and the left brachiocephalic vein. So as I mentioned, more than 50% of the masses occur in the prevascular space of the mediastinum. And most of these tumors are thymic in origin. These could be epithelial or non-epithelial. Epithelial tumors include thymoma and thymic carcinomas. And non-epithelial tumors could be like lymphomas, carcinoid, germ cell tumors, lipomas, liposarcomas, and there could be some other rare tumors like sarcomas. All the time we talk about these 4 T's of the prevascular mediastinum, which consists of thymoma, teratoma, terrible lymphoma, and thyroid goiter. But it is important to remember that based on the newer classifications, which is based on CT, thyroid goiter often extends to the visceral space. So this is an example of a multinodular goiter. We can see this is extending to the visceral space, which is next to the trachea and behind the vessel, behind the pericardium. So it is important to remember this is not only confined to the prevascular mediastinum, it can extend to the visceral space also. So we're gonna start with basic classification of the tumor which occur in the prevascular mediastinum. So again, this is they could be either cystic or solid. 2 common cysts which occur in prevascular mediastinum is a thymic cyst or the pericardial cyst. And some of the tumors like thymoma or germ cell tumor, they can be predominantly cystic. And this is a situation where MR can be helpful. Among solid tumors, thymic neoplasm is the big chunk. And then we can also say lymphoma. Primary mediastinal lymphomas are rare, but they can occur. Germ cell tumors, thyroid goiter, and thyroid neoplasm. Then we'll talk about the fat-containing neoplasm, which includes germ cell tumor, thymolipoma, lipoma, liposarcoma. Those are the most common, but some other tumors can occur. Based on calcifications, germ cell tumor can contain calcification. Thymoma can also have calcification. Lymphomas usually not, but treated lymphoma can show calcification, and sometimes calcified aneurysm can appear as a prevascular mediastinal mass. So we will start with the cases now. So this is a first case. This is young woman with incidental mediastinal mass. As I said, most of these masses are incidental, patients may not have any symptoms. So this patient has this very well-defined lesion in the prevascular mediastinum. On CT, it was fluid in attenuation. And on MR, we can see it is high signal intensity on T2, and it is not showing any enhancement with gadolinium. So this is a typical example of a thymic cyst based on the location, based on the imaging characteristics on CT and MR. So in these cases, like when we have a fluid attenuation lesion on CT, we do not actually need MR to characterize these lesions. We can just very comfortably say on CT, this is a fluid density mass, and this is a most likely a thymic cyst, right? If there is no any other concerning imaging features, we can definitely say this is a thymic cyst, and in like circumstances we ask for imaging follow-up. So this was a case of thymic cyst. So now this is a typical example of a pericardial cyst. Again, this was a incidental mediastinal mass. We can see there is a opacity at the cardiophrenic angle, and on CT we can see a fluid attenuating lesion in the right cardiophrenic space or pericardic space. So this is a very typical example of a pericardial cyst. Again, we do not need any other further imaging on this patient to characterize these lesions. So this is a pericardial cyst. So now look at this case. Now this is again an incidental mediastinal mass which is located in the prevascular mediastinum. So now this has attenuation of 62, which is more than a fluid. So now this could be a cystic lesion with high attenuation content, which is most likely a proteinaceous content. But to be certain, this is not a solid thymic lesion, like a thymoma. We need to do MRI in these cases. So we went ahead and did MRI in this case, and you can see on this is hyperintense even on T2, T1, and hyperintense on T2. So it's hyperintense on both T1 and T2. T1 signal can be variable, could be isointense, could be hyperintense, could be hypo or hyperintense or isointense. But usually with the cystic or solid neoplasm, we expect to see T2 hyperintensity. Most importantly, gadolinium. So on gadolinium, we do not see any post-gad enhancement. And we also do our diffusion weighted sequences in these patients, and there should not be any restriction of the diffusion if it's just a fluid attenuation lesion. So this is a T1 hyperintense, T2 hyperintense, and non-enhancing lesion on post-gad. So this is a thymic cyst. So we were able to resolve this as a thymic cyst over thymoma. So this is another patient. This patient has chest pain. Now we can see on CT, this looks a little bit complex. There is a more lower attenuation in the center, and a little bit looks like a more soft tissue at the periphery of this lesion. Localization wise, this is in the prevascular mediastinum. So we did MRI. So on T1, this is mostly hypointense. On T2, we can see there is a differential signal intensity. It is more hyperintense in the center and hyperintense, a little bit more hyperintense in the periphery of this lesion. On post-GAD, we can see there is enhancement of this lesion peripherally. There's a soft tissue, which is like it's more than just a thin wall. It's looked like a thick soft tissue in the periphery of this lesion. And there was this small amount of soft tissue nodule in the center of this lesion. So this is not like a typical thymic cyst or simple thymic cyst. So this patient underwent surgery. This was surgically resected, and this turned out to be a cystic thymoma. So here we can see again how MRI is helping us to further manage these patients, to decide whether we can just stop following up these patients. We can say these are like benign thymic cyst, or we need to do something like a follow-up imaging, or we need to take the patient to the OR. So look at this patient now. This patient again presented with chest pain, young patient. Again, we have a lesion in the prevascular mediastinum. It looks predominantly cystic again on CT. We can see there are two different density. This is more like a lower density. There's a little bit higher density at this peripheral location here. On MR, on T1, we can see there is this hypointense wall of this lesion. And then we can see there is a kind of a slightly hyperintense lesion, this with some maybe this wall, and there could be some septations. On T2, we can again see this like a two different signal intensity and this nice hypointense wall. On post-GAD, we can see this wall is enhancing, and there's a little bit of nodularity we can see here. So this patient was again taken to OR, and this turned out to be a multilocular thymic cyst. So this is a benign condition, but sometimes it's difficult to differentiate definitely based on imaging. So this is a multilocular thymic cyst. All right, so this is another situation where MR is helpful. So now this patient is young patient undergoing treatment for leukemia. This patient has this triangular bilobed soft tissue density lesion in the prevascular mediastinum. So if I'm reading this case, I know this patient has a malignancy, which is a stressful situation. And it's common to see thymic hyperplasia or rebound thymic hyperplasia in these patients. So when I see this kind of imaging pattern, typical shape, bilobe triangular shape conform to the shape of the thymus, and there are some interspersed fat in between. I'm very comfortable calling this most likely a rebound thymic hyperplasia, and I would recommend a follow-up CT in couple of months to make sure this is either remaining stable or resolving. So that's what we did in this patient. We asked the patient to come back in 12 months, and we can see already this patient is undergoing fatty involution again. So this is a rebound thymic hyperplasia based on the patient's physical stress, which was leukemia. So in certain stressful conditions, thymic hyperplasia can reoccur. Usually, thymus starts to undergo fatty involution in the second decade around adolescent. And then by the age of 30 or 40, it's mostly replaced by fat. But patients who are undergoing some stressful situation, like, patients who have malignancy, undergoing chemotherapy, radiation therapy, or taking a high dose steroid, or burn patient, those are physical stressful situations which can lead to rebound thymic hyperplasia. So this is an example of a rebound thymic hyperplasia. So in this case, we do not need MRI. We can just ask the patients to come back in few months, and then we can just do a follow-up imaging and see the evolution of these cases. So these are the rebound thymic hyperplasia. How about this case? So this patient, another patient with breast cancer, young patient who has this soft tissue lesion in the prevascular mediastinum. So now, in the absence of any prior imaging, we do not know what is going on here. This could be a metastatic disease, could be a primary thymic neoplasm, or this could still be a rebound thymic hyperplasia because patient is having a malignancy in young patient, right? So we did MRI in this patient. So MR with chemical shift imaging is helpful to resolve whether this is a thymic hyperplasia or a primary thymic neoplasm or some other neoplasm. So in-phase and post-phase imaging is helpful to resolve this. If it is a thymic hyperplasia, we expect to see a signal drop on post-phase imaging, as we are seeing in this case. Whereas if it is not showing any signal drop, that means this lesion is not having any intracellular microscopic fat, and this could be a solid thymic neoplasm. So, but in this case, we saw this loss of signal on post-phase imaging. So this is another case of a rebound thymic hyperplasia. So this is very helpful when we have this kind of imaging pattern, which is not. So this is a rebound thymic hyperplasia where MR was helpful. So now let's look at this case. So this is a patient who presented with chest pain. Am I audible okay? I'm getting just this message on my screen.
Yes, you're audible now.
Okay, awesome. Did I lose my voice in between?
Yes.
Oh, I'm sorry.
Very short moment.
Probably there's some signal issue, networking issues. So, okay. So this is a 55-year-old man with chest pain. We can see a very well marginated mass. Here we can see one sign on chest radiograph, which is called a hilum overlay sign. We can see the hilar vessels through this mass. So when we see this hilum overlay sign on chest radiograph, it basically tells us that this abnormality is either anterior or posterior to the hilum. This is not originating within the hilum. Okay, so this is the benefit of looking at this hilum overlay sign, which tells us to localize this mass either interior or posterior to the hilum. So when we do a lateral radiograph, we can see this mass is anterior to the hilar structures, and this is a mass located in the prevascular mediastinum. So this is a well-marginated mass in the prevascular mediastinum, very homogeneous mass, and looks like it is maintaining the fat film with the adjacent structure, looks like no invasion. So based on patient's age, 55-year-old, and this morphology on CT, we would call this as a most likely a thymic neoplasm, and most likely it is a thymoma. So this is indeed a case of thymoma, right? So how about this case? Now, this is a patient who is a 64-year-old woman with chest pain. Now, again, so thymoma usually occurs within 4 to 6 decades. So this is like a good age for thymoma. Now, this patient has this kind of a mass, is a little bit lobulated mass. It's not smooth as the last case. And we're also seeing calcification within this mass. So remember, I mentioned like we can see up to 40% of cases of thymoma cases can have calcification, right? So this is a thymoma with calcification. And it's like very like common to see pleural mets because of the invasion of this thymoma to the adjacent pleura. It's common to see pleural mets, and sometimes with the initial presentation, you can see pleural mets in these patients. So when we're seeing a prevascular mediastinal mass along with a pleural nodule, it's very, we should be comfortable in calling this as thymoma with pleural mets. If we do not have any other, like we do not have any lymphadenopathy, no disease outside the chest, we are just seeing a like a prevascular mediastinal mass, which looks like a lobulated or invasive, along with the pleural nodules. So we can call this most likely thymoma with pleural mets or drop mets, right? So this is a patient with thymoma with drop mets. This slide is showing basically different imaging patterns. It's showing how it can be difficult, not always easy to come up with a single diagnosis of thymoma when we see abnormality in a prevascular mediastinum. So in this case, we can see image on the left. The thymoma is a very small nodule, well marginated small nodules. This is a thymoma. This in the center, has a more lobulated contour. And on the right side, we can see this is more of an invasive disease, invasive tumor, which is invading the SVC and the other vascular structures in this patient. So these are all different spectrums or different like a morphological grading of thymomas. I'm not going into details of the grading of the thymoma. That's a separate talk for the thymic epithelial neoplasms. So this is just approach. So this is an invasive thymoma. This could be invasive, non-invasive. This looks like a non-invasive thymoma. All right, so next patient is a 72-year-old man with chest pain and shortness of breath. Now look at this case now. Again, we have a mass which is not very well marginated. It looks like an invasive tumor in the prevascular mediastinum. And in this patient, we can see this patient has a lymphadenopathy. We can see there's a lymph node in the right paratracheal space. And we can also see it is invading the pleura. There is a small amount of left pleural effusion, right? So pleural invasion, we are seeing lymphadenopathy, and on lung window, we are seeing this nodule. So when we see this imaging pattern, look like mass, which is looking like a kind of an invasive tumor, it might have calcifications. It's invading the mediastinal structures. It has lymphadenopathy. It is going to the lungs. It might be going outside the lungs also. So when we have this imaging pattern in an older patient, then you think about the thymic carcinoma. Okay, again, this is not we cannot make definitive diagnosis based on imaging, but we can suggest this could be a thymic carcinoma, and the definite diagnosis comes on biopsy. So that was a case of thymic carcinoma. Now another patient, kind of a similar pattern, but look at the patient's age. This patient is 20-year-old, not like last patient was in 70s. Now this patient is in 20. Now again, we have a lobulated mass in the prevascular mediastinum, which looks invasive. And then there are nodules in the lungs. We can see these well-discrete nodules in the lungs. And there are small pleural effusions, right? So now, based on patient's age, we will not be calling this as a thymic carcinoma, right? So what tumors can occur in the prevascular mediastinum in this age? When we talk about those 4 Ts, then think about, okay, this could be a teratoma, or this could be a lymphoma, right? So those are the 2 possibilities. Lymphoma could be a primary mediastinal lymphoma, or it could be a systemic disease, which is involving both mediastinum as well as lungs. So now the patient has elevated beta HCG. So when we have this tumor marker, when we know this, if we go into the patient's chart and we find out the patient has elevated beta HCG, then we are comfortable calling this as a germ cell tumor or teratoma, right? But when we do not have this clinical information, it is difficult to differentiate this from the lymphoma. Then we have to give both differentials, and the definite diagnosis come on biopsy. So this was a non-seminomatous germ cell tumor, which was a choriocarcinoma more specifically in this patient. Now, this is another young patient with shortness of breath. We can see there's a mass in the prevascular mediastinum. Looks like a little bit of lobulation in this mass, homogeneous mass. Patient's do not have any other symptoms. So these patients, this diagnosis was made on a biopsy. But when you see again young patients, homogeneous mass or heterogeneous mass, you can suggest either could be a germ cell tumor or it could be a lymphoma. So remember, germ cell tumor can also contain fat and calcification. I'm talking about the germ cell tumor which are not containing fat, non-fat containing and not calcified. So those tumors are difficult to differentiate from the lymphoma. So this is a patient with primary mediastinal B-cell lymphoma. Lymphoma patients sometimes can have B symptoms like weight loss, fever, and night sweats. So these symptoms may be present up to like 50% of cases, but those symptoms are again very non-specific. So, but symptoms are present, young patient, you can suggest could be a lymphoma. And if the disease is located outside of chest also, then it sometimes easy to differentiate one over the other. So these are the different spectrums of lymphoma. So it's not easy just based on imaging to label this as a lymphoma, but based on the other patient's demographic and other imaging findings, we can suggest or come up with this as a first differential. So this is a patient with primary mediastinal or thymic B-cell lymphoma. This was a diffuse large B-cell lymphoma, and this was a Hodgkin lymphoma. So patient's age is helpful to differentiate lymphoma from the non-fat containing germ cell tumors. So now this is a patient with Hodgkin lymphoma who has a involvement of the more than one mediastinal compartments. We can see lymphadenopathy is also seen in the visceral space, right paratracheal space, right? And there is also in the right internal memory lymph node, internal memory chain is involving. So when we have a multiple compartment involvement or involvement outside the chest, predominant lymph node involvement, then it is easy to call lymphoma. But when we have a primary tumor within the mediastinum, then it is not easy. So this was a multi-compartment involvement. It's easy to say this could be most likely this is a lymphoproliferative disorder or it's a lymphoma. So if I now show you this slide and ask you which patient is which, probably nobody can answer, right? Unless I give some more imaging clues or demographic clues, right? So this is a case of Hodgkin lymphoma. In the center, we have a non-germ cell tumor. This is more kind of a necrotic tumor. And this is a patient with thymoma. So again, based on just imaging pattern, it is not easy to differentiate non-fat containing solid tumor in the prevascular mediastinum. Patient's age, other imaging clues can help us to narrow the differential or favor one over the other. So now let's talk a little bit more about the germ cell tumors. So these tumors they derive from the primary germ cell tumors, and mostly occurs in the prevascular mediastinum outside the extragonadal site. Teratoma, seminoma, or non-seminomatous germ cell tumor, they are the common these germ cell tumors. Based on imaging, we can try to differentiate between the mature teratoma, which is benign teratoma, from the immature teratoma or a non-teratomatous germ cell tumors. So mature teratoma, they are usually well defined. They can contain fat and calcifications, and when we see fat food level, we are more confident in calling this as a mature teratoma. It's very common to see fat food level in mature teratoma rather than in immature teratoma, which is more kind of a invasive tumor or more larger tumors. But they can contain fat and calcifications. Whereas non-teratomatous germ cell tumor, which includes seminomatous tumor and non-seminomatous tumor, they almost exclusively occur in male patients, young patients, and they can have elevated tumor markers like elevated AFP or beta HCG. And we can see metastasis in these patients. We can see lung nodules or metastatic outside the chest. So when we have these imaging pattern, then we can favor non-teratomatous germ cell tumor. So based on this imaging now, we have a very discrete tumor containing fat and calcification. This could be a calcification or this could be a tooth, right? Because these tumors can contain tissues on any of the germ cell layer, right? So this could be a tooth or calcification. So this is a case of a benign mature teratoma. Now these two examples, look at this. Same patient. We can see this patient has a very large tumor containing areas of fat and calcifications. Very heterogeneous looking, invasive looking tumor, large tumor. So this patient has a elevated AFP. So this was a mixed germ cell tumor. It has both teratoma and non-teratomatous component. So this was a mixed germ cell tumor. All right, so let's talk about a little bit more about the other fat-containing tumors in the prevascular mediastinum. So this is a young girl with no chest symptoms found incidentally. So this patient has a predominantly fat-containing mass, which is conforming to the shape of the thymus. We can see the shape of the thymus. And this has a little bit of soft tissue, this septations or this little bit of soft tissue. So this is a case of a thymolipoma, which is again a benign tumor predominantly containing fat, small amount of soft tissue, conform to the shape of the thymus, and this can be very large at presentation because patients are mostly asymptomatic. So these are the three different examples of liposarcoma showing how liposarcoma can involve different compartments of the mediastinum. So this tumor is located in the prevascular mediastinum. We can see here, this is mostly fat and a little bit of this thin septations. So this was a well-differentiated liposarcoma. These are more like an invasive kind of liposarcomas. We can see this as tumor in the prevascular mediastinum, also in the visceral space, probably also going in the posterior mediastinum or paravertebral space. This is again same going into the prevascular mediastinum, visceral space, and posterior mediastinal space. So these are different examples of liposarcomas involving multiple mediastinal compartments. All right, this was an interesting case. So this patient has this, fat-containing mass with all this kind of, soft tissue and this vascular structures within this mass, which are not like avidly enhancing, but they were enhancing. And then we see this calcification of phleboliths within this mass. So this is a case of hemangioma in the prevascular mediastinum. So this is again not an easy diagnosis to make when we have this kind of, lesions with vascular structures. They could be like, highly vascular or like a low vascular, like a venous structure, capillary structure, which are slowly filling or less enhancing. So, and then we see phleboliths, prevascular mediastinum. So this is a case of hemangioma. This was an interesting case. So this patient presented with chest pain 4 months after cabbage. And there was nothing in the mediastinum before the surgery. So when we, the CT on this patient, we saw this kind of a fat-containing lesion, which has this soft tissue at the periphery, and there is a little bit of soft tissue, interspersed between this fat-containing lesion. So patient presentation was chest pain. So we thought this could be a fat necrosis. So we asked the patient to come back for a follow-up imaging because the surgical imaging was there's nothing there normal, right? So this was a, highly suspicious for a fat necrosis in the prevascular mediastinum. And the patient came back for follow-up. We can see at 6 months, 2 months later after this exam, you can see this lesion is, getting better, involuting. This is again, like, getting better at 2 months. So this was a case of a mediastinal fat necrosis patients after surgery. These are examples of some mimics of fat density lesion within the prevascular mediastinum. So we can see this is a fat-containing mass. We can see in this example on the left side, we can see there is a small like a vessels within this mass, whereas this lesion on the right side looks kind of a more homogeneous fat-containing lesion. So on the image on left side, we can the coronal reformat, sagittal reformat, and this patient is showing a defect in the diaphragm, anterior diaphragm. We can see this fat with the vessel is going from the abdominal cavity to the thoracic cavity. So this is a case of Morgagni hernia, and this is a case of a prominent pericardial fat pad. So in these cases, when we're suspecting a Morgagni hernia or herniation of the fat, sagittal or coronal reformat images are very helpful to show the herniation of the fat from the abdominal to the thoracic cavity. Now, moving to the visceral mediastinum. As we talked earlier, this is a space between the pericardium and then this imaginary line, which is 1 centimeter behind the anterior margins of the vertebral bodies. So important structures within this is the heart, trachea, esophagus, ascending aorta, aortic arch, and some other vascular structures, right? So now this space is, specifically we see some hypervascular lesion within the visceral space. So now let's look at this example. So this is a 54-year-old woman presented with back pain and found to have this mediastinal mass incidentally on a spinal MRI, which was done for a back pain symptom, right? So we can see there is this, so the CT was done later, right? So we can see this hypervascular mass. We can see this kind of, some areas of necrosis within the mass. And when we look at this MRI, which was done specifically to characterize this mass now, we can see this mass is isointense on T1, hyperintense on T2, and it's avidly enhancing with some areas of necrosis in the center. So this is located in the visceral space. So when we see a hypervascular mass in the visceral space, one of the differential diagnoses is the paraganglioma, especially if it is like a very high signal intensity on T2 and avidly enhancing. So this is a case of a paraganglioma. And paraganglioma is like, usually we see in the adrenal medulla or paravertebral regions or head and neck. These are tumors which arise from the neuroendocrine cells of autonomic nervous system. Mediastinal paragangliomas are rare, but it is one of the site for the extra adrenal, paraganglioma or involvement of this neoplasm. And middle mediastinum or visceral mediastinum and the posterior mediastinum are the common location within the mediastinum, most commonly middle mediastinum. And in the middle mediastinum also it's commonly seen close to the left atrium or in the left atrium. It can involve within the left atrium also. So another patient who has this chest pain, presented with chest pain, young patient, we can see this homogeneous mass which contains this calcification in the prevascular or in the visceral space or middle mediastinal space. We can see this is behind this right pulmonary artery. It's looking very hypervascular again on CT. So differential diagnosis again, could this be a paraganglioma? Yes, this could be a paraganglioma again. Could this be hypervascular lymphadenopathy? Yes, that's possible, right? So one thing we should think about when we see hypervascular mass in the mediastinum, when visceral mediastinum, is the Castleman disease. So this is an example of a Castleman disease, which is basically a angiofollicular lymph node hyperplasia, which is a benign B-cell lymphoproliferative condition. Traditionally, it was classified as a unicentric or multicentric, but more recent classification divides this disease into 4 categories, which is high vascular, plasma cell, human herpes virus associated disease, and Castleman disease, which is not otherwise specified. So high vascular is the most common, young patients, and usually unicentric. Whereas plasma cell and HH8 associated diseases are mostly multicentric and occur in older patients. HH8 associated disease is seen in immunocompromised patients. Patients who have a unicentric disease, they have a better prognosis. They can be surgically resected, whereas patients who have multicentric disease, they are basically treated as a multicentric malignancy with chemotherapy or other immunotherapy drugs. This is another example. This is a good patient of a hypervascular lesion in the visceral space. So this is a woman with the primary hyperparathyroidism. This patient has an elevated serum calcium level, and thyroid, primary parathyroid were normal. There was no any adenoma in the parathyroid. So this patient underwent imaging workup to find out the ectopic parathyroid, and we found this hypervascular lesion in the visceral space, which is next to the esophagus and behind the trachea. So this is the nuclear medicine hyperthyroid scan. We can see on the initial phase, there's showing uptake in the thyroid, which is washed out on delayed phase imaging, but we can still the persistent uptake in this parathyroid, ectopic parathyroid lesion. So this is a case of an ectopic parathyroid presenting as a hypervascular mass in the visceral mediastinum. right. So these are examples, different examples of a hypervascular lesions in the visceral space. As I mentioned earlier, goiter can extend to the visceral space. This is an example where we can see this third goiter with calcification in the visceral space. On coronal image, we can see continuation of the mass with the neck thyroid. It is extending to the visceral space. And this is a patient with the metastatic RCC who has this hypervascular lymphadenopathy involving multiple compartments. So that's another differential diagnosis for a hypervascular lesion in the visceral space. But mostly you see the lymphadenopathy outside the visceral space in the prevascular mediastinum also in patients who have this hypervascular metastatic disease. All right, so this is another patient with a lesion in the visceral space next to the esophagus. We can see this patient has a history of malignant melanoma, was getting staging CT, and was found to have this lesion adjacent to the esophagus, but there was no chest symptoms. So asymptomatic patients. So this is a case of a esophageal leiomyoma, which is again, benign tumor. It could be malignant when it's differentiated into the sarcomas, but when it is not, it's well defined. It's a benign entity. It usually arises in the wall of the esophagus. We can see here. So a patient may be asymptomatic. They may have, when it is large, compressing the esophageal lumen, may have symptoms, but they could be just asymptomatic. All right, so this patient again has no symptoms. We can see mass in the visceral space. So this is a very fluid density mass. So the common cystic lesion in the visceral space is the foregut duplication cyst, right? Which could be next to the esophagus or next to the trachea or bronchus. So this is a very fluid attenuating lesion. When we see a typical fluid attenuation on CT, we can just label this as a foregut duplication cyst, and these patients do not need any further imaging to characterize these lesions. So MRI is useful again when the signal intensity or density is higher in these patients. Here is an example. This is a patient who has this well marginated homogeneous lesion in the visceral space next to the esophagus. We can see this was high density on CT. It was in 60 Hounsfield unit. And on MR, we can see this is hyperintense on T1, hyperintense on T2, and there's no enhancement with GAD. So this is a example of a foregut duplication cyst, which was high density or proteinaceous cyst on a CT. So now lastly, we'll talk about the paravertebral space, which is this space in purple or pink behind this posterior line, which is behind this vertebral margins. So most common tumors in the posterior mediastinal paravertebral space are neurogenic tumors. As we all know, they could be cystic or solid. So cystic, when we see cystic neoplasm, those are usually meningocele. So this is an example of a meningocele in patient with neurofibromatosis. This is a large fluid density lesion extending into the neural foramen spinal canal. We can see MR has a better, characterization of these lesions. We can see the spinal cord association of this entity. So this is an example of a meningocele. Solid tumors, which we see in this paravertebral compartment, are mostly neurogenic tumors, mesenchymal tumors, osseous tumors, and some other miscellaneous conditions. So here's an example of another hilum overlay sign. We can see here hilar structures through this mass, but we can see this lesion is silhouetting the upper aspect of this left heart border. So on lateral view, we can see this mass is located posteriorly. So this is a hilum overlay sign with the posterior mediastinal mass. So this is a case of a schwannoma, in the paravertebral space. It can extend into the neuroforamina, may have, dumbbell-shaped appearance. So this is a typical example of a schwannoma, or, neurofibroma can look very similar. So this is MR in the same patient, hyperintense on T1, hyperintense on T2. It's enhancing with gadolinium. This is an example of a spindle cell sarcoma, which is a mesenchymal neoplasm in patient who has this mass, which is predominantly located in the paravertebral space or posterior mediastinum. Looks like a little heterogeneous mass with some areas of necrosis. So again, diagnosis in these patients is usually made with biopsy, but localization is helpful to narrow the differential diagnosis. So this is an example of a osseous tumor in the paravertebral space. This is an example of a metastatic chondrosarcoma involving this vertebral body. We can see there is a this mass, lobulated mass in the arising from this vertebral body. So this is an example of a chondrosarcoma. All right, so this is one of the miscellaneous conditions which can occur in the paravertebral space. This is a patient with a, I think, leukemia who was found to have this soft tissue, homogeneous soft tissue in the paravertebral space bilaterally. So this is an example of a extramedullary hematopoiesis. This condition can be unilateral or bilateral, can appear as a homogeneous soft tissue mass, which enhances with the contrast, but over a period of time, this undergoes decrease in size, undergo fatty involution. So in the chronic cases, you can see fat within this soft tissue region. So this is an example of a extramedullary hematopoiesis. So to summarize, localization of the mass within the mediastinal compartment is the key. That's the first step. CT is the imaging modality of choice for characterization of these lesions or entities, masses, or abnormalities. MRI is the problem-solving tool. It is imaging modality of choice for the posterior mediastinal masses. Patients' demographics, patients' age, patients' gender, and if we have some lab information like tumor markers that can help in differentiating the tumors, specifically germ cell tumors, and MRI is problem-solving tool. So yeah, that's about it. Thank you, everybody. Thanks for listening.
Thank you, Dr. Ahuja, for
For any questions.
phenomenal gamut of imaging of mediastinal masses. So there are a couple of questions in the Q&A. First one,
Sure.
which was, how do we differentiate rebound thymic hyperplasia versus involvement by ALL in young adults? Is PET-CT a problem solver?
So thymic hyperplasia and ALL.
Yes.
Yeah, thymic. So I mean, again, MR is helpful in differentiating thymic hyperplasia from any other neoplasm. We are not expecting to see leukemic involvement of the prevascular mediastinum, which chloroma sometimes can occur in the prevascular mediastinum. So we are not expecting to see signal drop off with MRI opposed to chemical shift imaging in patients who have a neoplasm, whereas thymic hyperplasia is going to show signal drop. And some patients of thymic hyperplasia, they do not show signal drop. There are some quantification of that loss of signal. There's a formula which we can use to calculate the signal drop. If subjectively or visually we are not seeing signal drop, we can use that equation to calculate the signal drop for thymic hyperplasia.
Awesome. So the last case you showed was a case of extramedullary hematopoiesis in a patient with leukemia. Can one
Yes.
effectively differentiate between the two on a single imaging?
No, again, this is, yeah. So lymphoma, if somebody tells me this patient has a lymphoma, so this can look very similar. Lymphoma can look very similar, or some other I would say histocytic conditions can look very similar. So but given the patient has leukemia, and if we have a previous imaging, there was nothing there. And if we have a follow-up imaging, this looking very stable, so then easy to diagnose thymic hematopoiesis. But based on single imaging, again, we suggest a diagnosis, we make a short list of differential, and we favor one over the other. Like when I'm reading this case, I know patient has leukemia or anemia, then I would favor this as my first differential. But I can say lymphoma is not lymphoma or leukemia is on the differential. It's not definitely excluded, right? So patient has leukemia, I would not say leukemic infiltration is excluded. This is favor to be extramedullary hematopoiesis. Yeah.
would you recommend a technetium 99 RBC scan?
That is one of the scan you can do for but usually we do not do, and it's a benign condition. Most of these patients also undergo PET-CT for imaging, leukemia lymphoma patients. So if there is no FDG uptake, we're not expecting to see FDG uptake similar to the leukemic or lymphoma infiltration elsewhere in the body. So if you're not seeing, FTG uptake, or we are seeing like a low level FTG uptake, so this is most likely a hematopoiesis. We often do not recommend a technetium scan, but this is something which can be performed. Yes.
Thank you. That's quite helpful. There's another question. What is the difference between thymic carcinoma and invasive thymoma? Perhaps
Yes.
to know whether it can be differentiated on imaging.
Yeah, so both are thymic epithelial neoplasm. So diagnosis, these are pathological diagnoses, invasive thymomas based on the grading of the thymomas and the thymic carcinomas. So on imaging wise, this is like differentiating invasive thymoma from thymic carcinoma. That's a pathological diagnosis, right? So we cannot differentiate based on imaging, but we can favor, as I mentioned, we can favor invasive thymoma over thymic carcinoma. It's less common or uncommon to see lymphadenopathy with invasive thymoma, whereas with thymic carcinoma, you can often see lymphadenopathy. And again, disease outside the chest is less common with invasive thymoma, whereas thymic carcinoma can metastasize outside the chest. So if you're seeing like a pleural abnormality, pleural invasions, or pleural nodules, that could be both thymoma or thymic carcinoma. But if you're seeing a lung nodules, or we are seeing a disease outside the chest, like a liver mets or bone mets, that's more likely to be thymic carcinoma.
Perfect. And can thymic carcinoma be differentiated from teratoma or germ cell tumor?
Yeah, again, germ cell tumors, non-fat containing germ cell tumors, age is the important, when we are making the differential diagnosis. We expect to see these non-fat containing germ cell tumors in patients who are less than 40, whereas thymic carcinomas are seen in patients in 60s and 70s, right? Six or seven decade. I showed two examples. They look very similar. Both have lung nodules, right? So it's not easy to differentiate based on imaging, but patient's age can help to differentiate non-fat containing these thymic tumors from the thymic carcinomas. And then second point is the if we have those tumor markers, beta HCG, AFP, or LDH, those can help to narrow the differential.
Then someone would also like to know, can imaging help in differentiating SGCT from NSGCT, seminomatous from non-seminomatous germ cell tumor?
Yes, that is that is something which is again that's a diagnosis which comes on biopsy. So based on the tumor markers, seminomatous tumor, usually their alpha protein level is normal, whereas non-seminomatous tumor, they have high AFP level. So this is something which is a tumor marker, but that's again not definitive. So solely based on imaging, I do not think it is possible to differentiate non-teratomatous tumor like seminomas and non-seminomatous germ cell tumor just based on imaging. So this is something which is again, diagnosis is made on biopsy. So tumor markers can help, but not definitive.
Okay. How to confidently differentiate fibrosing mediastinitis from more aggressive visceral compartment lesions like aggressive NHL without demographics or risk factors?
Yes, so yeah, that's another very important differential. That's a very good question. So fibrosing mediastinitis and then more aggressive like lymphomatous tumor or some leukemic tumors. So so fibrosing mediastinitis, it's usually like, it's a chronic process. Patient have like a background of prior granulomatous disease, either like a tuberculosis or histoplasmosis, so in here we see mostly histoplasmosis, whereas in India, we commonly see tuberculosis as the main differential for the fibrosing mediastinitis. So you would see that narrowing of the airways or vascular structures, and you can see calcification, you can see other stigmata of granulomatous disease. You might see like calcified lymph nodes uh, in these patients, to differentiate patients' prior imaging, history. Again, lymphoma would have more widespread involvement. Lymphadenopathy will be more widespread. You don't expect to see that with, if it is a chronic fibrosing mediastinitis. Usually, it's a chronic process. You do not see that fibrotic process may be active, may show FDG uptake, but it's a chronic process, right? So I think based on other imaging pattern, presence of this uh, gradual narrowing or occlusion of the vascular structures, airway structures, their overall morphology is very ill-defined looking. They can look like mass-like, but they are usually very speculated lesions. And then presence of other granulomatous, lymph nodes. So those can be helpful in differentiating, definitely. Yeah.
There's another question. Could lung sequestration present as mediastinal mass?
So lung sequestration can present as mediastinal mass. Yes, it can, right? So on when we see at the on chest radiograph, definitely, But how about on so after localized, we need to characterize a lesion on CT. So on CT, you can see that vascular supply of the sequestrations. So it's easy to diagnose. It's not a mediastinal abnormality, right?
Yes. And
Yeah, that's
fat,
definitely. Yeah.
fat-containing lesions, thymolipoma, mediastinal lipomatosis, liposarcoma. Any heads up as to differentiation between these entities?
Yeah, I mean that's a good question again. So thymolipomas, as I mentioned, they are usually conform to the shape of the thymus, and you see predominantly fat, some soft tissue. Lipomatosis, it's usually like that fat is very soft brown fat. It's insinuate between the structures, right? So it's not like a discrete, or capsulated lesion as a thymolipoma. Lipomatosis is like a insinuation of the fat in between these structures. So that's how you differentiate. And then differentiating thymolipoma from well-differentiated lipoma or liposarcoma, that can be difficult. Yes, that can be difficult. So based on imaging, so that is difficult diagnosis to make, or probably you cannot differentiate the well-differentiated liposarcoma uh, or lipoma, unless we just, again, if it is just around the shape of the thymus, that is it. But no definite diagnosis. Whereas lipomatosis is more like, infiltrative, like fat.
Agree, quite challenging. And
Yeah.
we see in case of spindle cell tumor in the presentation. So was
Yes.
it a prospective diagnosis, or you would consider a host of differentials in such a case?
In this case, when you have a mass in the posterior mediastinum or paravertebral space, so differential again, mostly confined to the neurogen tumor or mesenchymal tumors, right? So, and the definitive diagnosis come from the biopsy. If it's a neurogen tumor, schwannoma, neurofibromas, they can extend to the neural foramen, go into the spinal canal, whereas other like those ganglioneuromas or ganglioneuroblastomas, they are more like in younger patients, more elongated tumors, cylindrical shaped tumors. So, but definitive diagnosis is mostly come from the biopsy.
Perhaps the last question, can lung cancers mimic mediastinal masses? If so, how to differentiate?
So, lung cancer, like small cell lung cancer, we as we know often present only as a lymphadenopathy. You may not be able to see, or patient may not have that lung nodule, or you may not see any lung nodule. You can see just a bulky lymphadenopathy. So then when we see that bulky lymphadenopathy involving more than one compartment, uh, they're aggressive tumors, small cell lung cancer, right? So it is difficult to differentiate those tumors from lymphomas when we're imaging a patient for the first time. So lymphoma is the most important differential when we have this multi-compartment lymphadenopathy, which could be a small cell lung cancer or a lymphoma. So one factor which favor this is malignancy. It's invasion, right? It basically invades the airways. It can cause the occlusion of the airways. It can invade the adjacent structures. Patient may present with the atelectasis, blockage, or SVC syndrome. So those are the findings which favor malignancy. So if we do not have the invasion of the structures, vascular structures or airway structures, we just have lymphadenopathy, then it is difficult. Lymphoma, on the other hand, lymphoma usually they encase or compress the structures or displace the structures, right? And aggressive lymphomas can invade, but most of the time, lymphomas are encasing or displacing or compressing those structures. Small cell cancers, they are very aggressive tumors, right? So they, when the patient has bulky lymphadenopathy, they are most likely invading the definitely airways and sometimes vascular structures also. So yeah, I mean, again, definitive diagnosis is on biopsy, but we can, suggest one over the other.
Thank you. Thank you. I mean, we really enjoyed your presentation and your thoughtful case-rich presentation with systematic approach towards mediastinal masses, how to differentiate using multiple modalities, CT scan and MRI between different mediastinal masses. It was really an eye-opener. And we also thank all our attendees for their thoughtful questions and active interaction during the Q&A session. And we thank everyone for being here with us. And we would love to see Dr. Ahuja frequently on the platform with
Of
more
course.
such presentations. Thank you
Thank
so
you.
much.
Thank you for having me, and thank you for this opportunity to present this talk. And I'm looking forward to come again on this forum. Thank you.
Thanks a lot. Take care, Dr. Ahuja. Stay safe.
Thanks. Yeah. Bye. Thank you.
Good day and good evening. Good night, everyone. Thank you.